So the ER visits have been something that we've been really obsessing over really since the late 90s. And we had a manual process, and then we tracked ER utilization. We had 10 doctors at the time, and there was a wide variation in terms of ER utilization. We standardized that manually, and then over a number of years, we looked at those metrics or parameters in that delivery column, the primary driver column, our practice, how we delivered care. We looked at some of the things that really had an impact on individual doctors' ER utilization. So there were a number of things that we had to do, and there were probably half a dozen different things that we fixed. One of them was having a note done in a timely fashion so that internally our triage nurses could have full visibility on what the symptoms were from 4 days ago, what the recommendations were, and what their current status was now. So internal data completed was a major issue. Having our nurses have algorithms that we've developed where there's a nursing domain and a physician domain, so that when the nurse gets on the phone, has full visibility of the patient's situation, she can follow an algorithm and execute a command without interrupting the doctor. If it goes in the algorithm into the doctor domain, the doctor has to get involved and maybe see the patient that day or the following day, depending on the acuity. So that's just two of the aspects. The other thing was, we centralized our triage service from our 3 sites. We got more consistent execution that way. And we also reduced our ER utilization by standardizing the way that we collect symptom data, patient symptom data at the time of the visit. So that if a patient comes in and remembers 3 issues, and there's a 4th and a 5th, and we address the 3, and the 4th ends up causing an ER visit, or the 5th does, between visits, we fail. So accurate data collection from the patient, data presentation that's consumable to the physician, and then having systems that make sure the physician's accountable for addressing those symptoms. So better control and better addressing symptoms at the time of the touch of the outpatient visit has also decreased our ER utilization. Another thing that has reduced it too is being mindful of their comorbid conditions. A lot of our patients are older, they have congestive heart failure, COPD. We are internists. If we have to touch up one of their meds and refer them back to their cardiologist, we're responsible for doing that. That keeps them out of the ER too. So there's really a half a dozen key points that can really drive down ER utilization.